Welcome back for part 2 of our lecture on gender dysphoria, sexual dysfunction, and paraphilic disorders. In part 1, we defined key terms such as sex versus gender and reviewed the diagnostic criteria for gender dysphoria in children, adults, and adolescents. In this lecture, we will review various types of sexual dysfunction, their prevalence, causes, and potential treatments. The general description for sexual dysfunction would be clinically significant disturbance in sexual response or the ability to experience sexual pleasure that cannot be fully accounted for by a medical problem. And we divide these into a variety of subtypes. These would be those that this was lifelong, so it's been present since their very first sexual experiences, or it's acquired, meaning they had a period of time with normal sexual functioning and then these problems began. Situational are those where sometimes they have normal sexual functioning, but then in certain situations or with particular partners or particular types of stimulation, they have sexual dysfunction. Or generalized, where there doesn't seem to be any limitation, they experience sexual dysfunction across all situations. So someone could easily have multiple subtypes where perhaps it is acquired and also generalized, or perhaps lifelong but situational. Because of that, sexual function involves a complex interaction between biological, sociocultural, and psychological factors. As a result of that, it's difficult to have a precise understanding of the etiology of a sexual problem. We typically just will not be able to tell. Instead, we would rule out problems that are better explained by a non-sexual psychological disorder. For example, if someone has depression, may not have much sexual desire, may experience sexual dysfunction, or if they are using a substance that may be affecting their sexual response, there are several medications or drugs that actually can reduce sexual interest and pleasure. They may have a medical condition. For example, pelvic nerve damage could reduce their ability to have sexual functioning. They may also have relationship stress. There could be partner violence or other stressors in their environment that are impeding their sexual functioning. This chart shows us that there are many people struggling with sexual dysfunction, and this can greatly impair their life satisfaction as well as their relationship satisfaction and the quality of their relationship. We also know that these problems are not the same across the sexes. The DSM no longer categorizes disorders in these broad categories, but I think they're still helpful for us to think through who is experiencing what. And they can help us show the range of dysfunction that people are experiencing as adults. The first bars are men in each category, and the second bars are women. What we can see immediately is that women have higher rates of sexual dysfunction across all categories except rapid orgasm. Men are the ones that are more likely to have rapid orgasm. Let's begin to talk about specific disorders. The first in this category is erectile disorder. Here, individuals have difficulty obtaining an erection, or they may have difficulty sustaining or keeping their erection. As a result, they see that they do not have the same kind of erectile rigidity, and they are unable to maintain or even attain in the first place an adequate erection. This needs to go on for at least 6 months and happens across all types of sexual activity. We know that erectile dysfunction does increase with age. Only 2% of men under 40 have erectile dysfunction, but 40 to 50% of men aged 60 to 70 will experience erectile dysfunction. And that dysfunction might be very mild. It can be more moderate, or it can be complete, where they are unable to have an erect penis at all. Most erectile dysfunction is related to health and psychological factors. So things like stress, alcohol, drugs, and diabetes. But the good news is, guys, if you would like to be in that category of those 70-year-old with no erectile dysfunction at all, which was nearly 40%, or those that have only minimal erectile dysfunction, which was another 10% or so, it starts by taking really good care of yourself now. So addressing your health, addressing your wellness now can give you happy penile functioning for decades and decades to come. Our next category is premature ejaculation. Here we see a persistent and recurrent pattern of ejaculation during sexual activity. It occurs within the first minute of penetration, and certainly it's occurring before they're wanting to ejaculate. It occurs for at least 6 months and occurs across nearly all sexual activity. Roughly 75 to 100% of the time, they're experiencing premature ejaculation. Someone may also have delayed ejaculation, where they are having a lengthy period of time of sexual activity and they cannot have an orgasm. As a result, there's an infrequency or an absence of ejaculation, and the individual does not want to have that delay. Again, we look for this happening for at least 6 months across all forms of sexual activity. Male hypoactive sexual desire disorder. Persistent and recurrent absence or very low rates of sexual or erotic thoughts or fantasies. They don't have any interest or any desire for sexual activity. This has been going on for at least 6 months. And we have to be thoughtful when looking at these things that we are accounting for the person's individual context. So what was their sexual norms and desires prior to the onset? We also want to be very careful about not labeling a disconnect between the person and their partner. It's very, very common that people will partner but have different sex drives than one another. And this can sometimes cause conflict in the relationship, and the person with the lower sex drive may come to think that there's something deficient with them because they don't match their partners. This is not the kind of situation that would count as male hypoactive sexual desire disorder. It really needs to be that they have this absence of sexual or erotic thoughts or fantasies and no desire for activity, not merely that they have that desire at times and it just isn't as frequent as their partner would like. We see this in approximately 6% of younger men between the ages of 18 to 24 and 41% of older men between the ages of 66 to 74. However, this persistent lack of interest in sex that lasts for 6 months or more is less than 2% of 16 to 44-year-olds. Female sexual interest arousal disorder. We're looking for at least 3 of the symptoms to count for this diagnosis. So an absence or reduced interest in sexual activity, absent or reduced sexual erotic thoughts or fantasies, no desire or reduced desire to initiate sexual activity, and they are unresponsive when their partner is initiating sexual activity, absent or reduced sexual excitement or pleasure during sexual activity in nearly all types of sexual encounters, absent or reduced sexual interest or arousal to sexual or erotic cues, and absent or reduced genital or non-genital sensation during nearly all sexual encounters. This has to continue for at least 6 months. And again, we would not give this disorder if it's merely a desire discrepancy with their partner. So their partner would like to have sex more often. They don't want to have sex as frequently, but they do still have desire for sex at times. Their body is responsive. They are interested. They have fantasies. That would not be a scenario that would count for this diagnosis. So we're really looking here for an individual that has no interest, or again, I'm going to say no interest, but we also talk about those with a significant reduction. Little or no response when they are engaging in sexual behavior, so their body is not being responsive, their body is not reflecting an interest, they don't think about it or have an interest or fantasies about sex or sexual interactions. And this is going across all situations, so it's not merely a partner issue. And we also would not label those who call themselves asexual. Asexual is a self-identification. It's not a psychological or physical condition. If somebody labels themselves as asexual, that would not mean that they automatically qualify for the diagnosis of female sexual interest or arousal disorder. In addition to the subtypes that we talked about earlier, lifelong or acquired, generalized or situational, we need to also think about 5 really important factors when we are assessing or diagnosing sexual dysfunction, because all of these are directly related to etiology and treatment. 1, partner factors. If the partner has sexual problems, if the partner has health challenges, the individual sexual dysfunction may be a reaction to factors with their partner. There may also be relationship factors. Are they able to communicate effectively? Do they have discrepancies in their desire for sexual activity, and that's causing conflict? We also would need to look at individual vulnerability factors. If somebody has poor body image, a history of emotional abuse or sexual abuse, if they have psychiatric diagnoses like depression or anxiety, or a lot of stressors, for example, job loss, a pandemic, bereavement, these will often interfere with sexual arousal, sexual desire, and sexual functioning. Cultural and religious factors. So being in a religious or a cultural context where there are a lot of inhibitions related to sexual activity, where sexuality is strongly prohibited or shamed, if there are a lot of negative attitudes around sexuality, very likely to have difficulties with sexual functioning and pleasure. And of course, if there are any medical factors that are relevant to the prognosis, course, and treatment, we would need to be considerate of those and thinking about how to move forward. Each of these factors contribute differently to this presenting problem and to the presenting symptoms for different women. So we need to have a thorough investigation of all of these various factors before we can fully understand what to do for the diagnosis as well as for helping them get better. The next one is genitopelvic pain penetration disorder, and this refers to 4 commonly comorbid symptom dimensions. First, difficulty having intercourse. This might range from a total inability to experience vaginal penetration. For example, they cannot have intercourse, cannot have a gynecological examination. They can't insert a tampon into their vagina, all the way to an ability to easily experience penetration in one situation, but then not in another. Genitopelvic pain. The intensity of the pain is often not linearly related to the distress or the interference with sexual intercourse or other sexual activities. So here the person might be talking about intense burning, cutting, shooting pains, or throbbing sensations, even though the activity that they're having would not typically cause that level of pain. Also, fear of pain or vaginal penetration. This may start out as a very normal reaction to having had a painful experience, but now it's leading to avoidance of sexual or intimate situations, and now the fear itself is causing them to have a reaction that further increases the likelihood of having pain. And tension of the pelvic floor muscles. This can vary from a reflex-like spasm of the pelvic floor in response to an attempt to have vaginal entry to a normal voluntary muscle guarding in response to the anticipated or the repeated experience of pain and the anxiety that causes. So in the case of these normal guarding reactions, penetration could actually be possible if they're able to relax. The prevalence of genitopelvic pain penetration disorder is not well known. However, we do know that about 15% of women in North America report having recurrent pain during intercourse, and difficulties having intercourse appear to be a frequent referral to sexual dysfunction clinics and to specialty clinicians. Our next disorder is female orgasmic disorder. Here, individuals have a marked delay in frequency of, or an absence of orgasm. Marked reduced intensity of orgasmic sensations are also possible. This has to continue for at least 6 months and spread across nearly all sexual activity. And then we would specify if they have never experienced an orgasm under any situation, and we'd add that as a specifier. Some women do indeed have greater difficulty communicating sexual concerns. Overall sexual satisfaction, however, is not strongly related with orgasmic experience. So many women can report having high levels of sexual satisfaction despite only rarely or even never experiencing orgasm. Orgasmic difficulties in women do often co-occur with problems related to sexual interest or sexual arousal. These various factors can come together to exacerbate the problem. There's also challenges with the lack of information many people have about women's orgasm. Many women do require clitoral stimulation to reach orgasm. There's only a very small proportion of women that report that they always experience orgasm during penile-vaginal intercourse. So that's actually quite rare. Therefore, women's experiencing orgasm through clitoral stimulation, but not during intercourse, does not meet criteria for a clinical diagnosis of female orgasmic disorder. And that is because that is actually the norm. the norm is that women will not experience orgasm during vaginal penile intercourse, that they do require direct clitoral stimulation in order to reach orgasm. And if they can reach orgasm from clitoral stimulation, then that is actually just normal functioning. And in thinking about challenges, even if they have some clitoral stimulation, we also need to consider whether the orgasmic difficulties are the result of an inadequate sexual stimulation. If it's inadequate sexual stimulation, they may still need care, but that would not be appropriate for this diagnosis. Prevalence estimates for women reporting having problems with orgasm range anywhere from 10% of the population to 42% of the population, and depends on a variety of factors like their age, culture, how severe the symptoms are, how long it's been going on. But these estimates are not taking into account the presence of distress, because a smaller proportion of women report having orgasm difficulties and also reporting significant distress. And it's important to note that approximately 10% of women do not experience orgasm throughout their entire lifetime. Female orgasmic disorder is far more prevalent because so little is known about female sexual pleasure. This is a 3D printed rendering of the clitoris. If it were to really be properly positioned, we'd need to flip it over, and I'll actually show you some images that will show it in the proper positioning. But most people think about the clitoris as only being that tiny portion circled here. But what should stand out is the clitoris is much more substantial than many believe. Most of the clitoris is actually hidden away below the surface. The proportion most of us know about is literally just the tip of the iceberg. The image on your left is the first 3D sonography image of the clitoris. And then the image on your right is the clitoris and vagina urethra all labeled, so you get an idea of what the structure actually looks like. So the yellow portion of the 3D sonography is showing the clitoris properly located within the body and demonstrating, the yellow is demonstrating just how sizable the clitoris is. But the clitoris has been ignored socially and medically. I went to the Body Worlds exhibit, and if you're not familiar with this, look it up, it's fascinating. They have a process of preserving the human body so that they can put people into different positions, and then they can demonstrate what does the body look like, say, running, or if you are pushing a stroller, all sorts of different activities. And they remove the skin so you can see the muscle and see how your body is performing that particular activity. So they have hundreds of different bodies displayed, and they also have parts where they've shown segments of the body so that you can see layers and where different pieces are located. I was in the section on sexual anatomy, and I noticed that the male anatomy was accurate and fully labeled, but the woman's anatomy was not. Notably, the clitoris was not identified. And I went to the on-site medical director to ask about it, and she could not tell me anything about the anatomy of the clitoris or why it was not labeled or discussed in the exhibit. So think about it. This was an MD who had little to no education about a part of the body that 51% of the population has. Socially and medically, we have erased information about the clitoris, and we've pathologized information about the clitoris. And this is actually quite problematic because it means we have a very rudimentary understanding of its function and how it plays into women's well-being. This sonography image of the clitoris, this was the first one ever done, and this was in 2009. So in all of human history, we only began to pay attention to this recently. We now know that the glans, which is that little portion that was circled earlier, it's the part of the clitoris that most of us will think about if we think about the clitoris. This little teeny section of the clitoris has over 8,000 sensory nerve endings. This is more than any other part of the human body, and it is twice the number found in the head of the penis. But the head of the penis serves multiple functions. You know, this is an area for releasing semen. This is an area for releasing urine. This is the area for experiencing sexual pleasure. So it's doing a lot of jobs. In contrast, the glans of the clitoris has no other purpose but to experience pleasure. And it is the only part of the human body that is exclusively devoted to feeling pleasure. The glans is connected to the clitoral shaft, which makes that area between the glans and the vaginal opening very sensitive. And you'll see that the clitoral legs become erect and they fan out when aroused, and the clitoral bulbs become enlarged or erect when aroused. And this is important because they surround the vaginal canal. So they are literally hugging the vaginal walls when they are aroused during intercourse. This is important because female orgasm has not been well understood and has even been pathologized in the past. I would even say in the present. In fact, for a very long time, the medical opinion was that the only proper orgasm was a vaginal orgasm, and that a clitoral orgasm was actually labeled as an immature orgasm. So it was being pathologized. What we now know after seeing the anatomy of the clitoris is that all orgasm is clitoral orgasm. The only reason some women can have an orgasm from penetration is because it activates part of the clitoris. Most women will only rarely have an orgasm from penetration alone, and that's because they're also having clitoral stimulation. But even then, most of them need additional clitoral stimulation to have orgasm. This entire thing has not been well understood until very, very recently. What are some of the causes for impaired sexual arousal or interest? We know that everyday hassles, anxiety, anger significantly affect sexual desire. So although on movies and TV, they always show this angry response turning into sexual arousal, in reality, that's not how things usually go. Angry couples do not have passionate sex. They rarely have sex at all. Physiological factors such as drugs and diabetes play a bigger role than even the psychological factors. Particularly when we're talking about erectile disorder, where alcohol, drugs, stress, and diabetes are critical in its development and maintenance. And when we're talking about really severe cases of sexual, more of an aversion, this is more often related to psychological factors rather than physiological concerns. There are several physical disorders that can cause pain during sex. So there may be medical interactions that have resulted in pain during sex. Some of the sexually transmitted infections, such as herpes or genital warts, can make sex very painful. If someone had a traumatic birth experience and pregnancy, or if they have yeast infections, any of these things can create pain during sex. So we want to figure all of those out and help the individual navigate those concerns if they are there. Some other factors that are associated with pain or vaginismus is sexual abuse and trauma, fears around sex, and these could be fears because of religious taboos and shaming that they experienced in their upbringing, but it can also be fears around pregnancy or fears around having pain. For premature ejaculation, this is going to often be linked to anxiety. And as a result, it's more common in younger men. So as men develop more familiarity with sexual activity, as they reduce anxiety in having performance with another partner, it will typically get much better. But as men age, erectile dysfunction is far more common than premature ejaculation. For women, what we know is that they need to learn how to experience sexual release, and they need to learn how their bodies work. So the lack of information about the clitoris also means that women typically do not know how their bodies work. They do not know where these different parts of their body are, and they don't have sufficient information on how to create sexual pleasure and how their body in particular responds to different sensations. And so although some may find this controversial, all of the medical evidence demonstrates that masturbation is actually protective. Women who masturbate are much less likely to experience any of the orgasmic disorders and to experience sexual dysfunction. But there's even research that shows that if adolescent girls masturbate, they're often going to be more confident and will demonstrate a reluctance to get into serious romantic relationships that are abusive. They will get out of a negative relationship faster and acquire less abuse as a result. They typically will delay sexual intercourse and will often make smart choices around requiring sexual protection during intercourse once they do have intercourse. I'm going to transition here into showing you a video that talks a little bit about some of the sexual diversity and the purpose of sex. And it's again from that movie of Redefining He, She.
All creatures are united through descent. We share a common ancestry with birds, fishes, trees, and every living thing. So what can nature Tell us about ourselves.
There's no precedent in nature for the rigid assertion of a male-female binary of the sort that people are supposed to be obeying. Nature consists of rainbows within rainbows within rainbows, so that even if one does manufacture some category, once you start looking within the category, you find variation within that. And then you could make a subcategory. You find variation still within that.
In the natural world, diversity is everywhere, from sex-changing fish to male seahorses that actually give birth. In some species, male and female are indistinguishable. In others, there are two or more distinct male or female genders. There are even species where intersexed bodies are in the majority. Some animals are promiscuous, others bond for life, and over 300 vertebrate species engage in homosexual behavior. But exclusive homosexuality is a human construct.
Animals don't do this knowing that they're going to reproduce. Animals do this because it feels good. And so, in fact, reproduction is slaved on the back of pleasure. Nature had to put it somewhere. And in Mother Nature's infinite wisdom, she put it with pleasure. Good thing if you're a male black widow who's going to be killed after your first sexual experience, or a grasshopper who's going to have your head eaten off after your first sexual experience. You've got to tie it to something that makes you unable to not do it. And pleasure is that system.
In nature, the giving and receiving of sexual pleasure has many benefits. It helps to diffuse hostility, encourage cooperation, and build alliances, whether the context is heterosexual or homosexual.
And the physical contact isn't limited, of course, to genital contact. There's a lot of grooming that goes on, a lot of very close physical togetherness, and it's by being together physically very close that they can work together. And you don't get team play without very close coordination.
Human sexuality is infinitely more complex. We have culture, religion, civilization. We have to resolve the conflict between our natural urges and the rules.
The take-home message of this segment of the video is that while sex does lead to procreation, of course, but it's far more than that. The fact that the clitoral glands are solely for sexual pleasure, and the fact that animals engage in sex for pleasure versus procreation, all of this shows that sex and pleasure from sex is a normal part of the human experience. And we could do a lot by helping individuals destigmatize sex and sexual pleasure and learn how to have healthy sexual pleasure in their lives. This is the end of part 2 of our lecture. Be sure to check out part 3 on paraphilic disorders.